Yes, yes. Thank you very much. Sorry for the delay. It's the problem with my laptop. So let's continue from the very same thing. So I wanted to show you exactly. So here you can see that there are some other functions. For example, this is called as loop speed. This is called as loop speed. You can create a video through the images, and then you can see the cycle select, start frames or end frame, and blah blah blah. So we'll immediately go to what to do when we turn on the machine and what to see. Or let's see, once we turn on the machine, it asks us to, connect the probe. So we have connected the probe already. In my case, it is the linear probe. If I press freeze or unfreeze, you will see the difference. So right now I need to click over here. Here you can see my depths, and I can disconnect the probe, and similarly I can connect the probe. As soon as I have connected the probe, now you see this screen has changed. On top you can see these gray lines, and now let me show you. This is called as a linear transducer. On the other hand, this is called as a curvilinear transducer. I believe you can have a clear difference right now. So this is called as linear and this is called as curvilinear. We are not using the curvilinear, but we are using the linear transducer. Over here you can read 8L. On top it is also going to tell us that which probe is used. On top, let me show you. So now you can see I have applied the gel, and here are the lines. If I press unfreeze and I place my finger on top of it, you can see an image is being created. Okay, so everything is fine. So now the image is created. We will discuss how to read the image, but let's see what can be done. As soon as I press the freeze button and even if I touch the transducer, nothing is happening. But when I unfreeze it and I move the finger close to the transducer, you can see that there are some images that are created. Okay, I hope everything is clear till now. Then let's see what are the other features or functions. So here I want you to start reading the screen from the top right side to the bottom. Now over here, MI is mechanical index. These are the mechanical effects. This is thermal index, the heating effects. This is the probe that we are using, 8LRS, and musculoskeletal is the function that we are using. B is denoting the mode of the ultrasound that we are using. I believe you can clearly see now. So B is for the brightness mode. FRQ is frequency. We are using 8 megahertz, and GN is for gain. So what happens if I increase the gain? You see the value of the gain getting increased, as well as the screen is getting more brighter. So if I decrease the gain value is becoming low and the screen is becoming less brighter. Okay, so it's similar to volume. If I increase the frequency, you can see now it is set to 10 hertz, it is set to 11 hertz maximally, and we can go 8 or 6 megahertz to the lowest. So let's keep it to 8 megahertz right now. Then we have E or A. These are some settings for eclipse area. So let's not change this eclipse area right now because we don't want to change it. Then map, this is gray mapping actually, so you can change the color of the gray. Over here, if I select the gray map, you see the value changes as well as the screen changes also. So these are just gray mapping. So anything that looks good to your eye, you can set that. D is denoting the depth. Now depth is 4 centimeter right now. Why I'm saying is because I want you to have a look at this from, let's move it a bit out of the, yeah, that's fine. So on the screen, this is 1, you can see 1, this is 2, this is 3, and this is 4 centimeter. And every centimeter is divided into 1, 2, 3, and 4 equal parts. So, you know, it's 0.25 of a centimeter. But if I decrease or increase the depth, now you can see that the depth is 0.5 and 1.5 centimeter. And if I keep on increasing the depth, you can see the depth is getting more and more and more till, you know, 11, 12, 13, and 14. So for me, 4 centimeter right now is good enough. Then you are looking at frame rate. Frame rate is the number of images taken per unit time. And then AO is acoustic output. That means the power of the ultrasound. So we can keep it 100 or we can change it. If we want, we can change it. So we can somehow change from the B mode or from these settings. Acoustic output can be, you know, increased or decreased. So it's always better to keep it to 100%. Then one important thing is that you need to understand there is this marker. I believe it's too bright for you guys, but let's try to see if we can uh, fix this. Can you guys know? I think it's, let me, does this change any, creates any difference? No, I think it should be set to auto, and somehow we can try to find out. Okay. So this is actually written, the word is called as GE. Let me show you. Let's take it out of the zoom and let me show you. Maybe now you can see, or can you turn off the light? One of the lights, please. The other one also. From here, from the back, keep it on. Now I believe this is a bit better than before. Let's select the uh, you see this is GE. Yes, you got it. So this GE is basically, you can turn it on. So GE is basically helping us with one thing, and that is a very important concept. Let me show you, or let me tell you. Please turn this off and keep the others on. There are 4 buttons. Yes, thank you. Okay, so sorry for the inconvenience. Now you see, this GE is telling us about the probe marker. Why I'm saying it is important, because there is a probe marker on every probe to tell us about the orientation of the probe. Okay, so let me show you the probe marker onto the probe physically, and we can also work. It's better. Okay, so probe marker is over here onto the probe, that is basically on each probe. So it tells us about the right and left side of the probe. Over here, this is the marker. You can see this is the probe marker. But on the other side, there is no marker. This is the probe marker. For this, they have this marker, this line as a marker. Okay. So this is called as a probe marker. You see no marker over here. So the probe marker is telling us that where is the probe right now. So please see I am keeping the probe. Let's say, or let's keep it fixed to the screen. I think this is even better. Yeah. So let me show you. The probe marker is towards the left side. I am rotating it to the left side. The G is written onto the left side. Now if I press over here, you see that the image is being created on the left side. So I know that the probe is towards the left side, so this is representing the left side and this is the right side. So if I reverse it, now the probe is on to the right side, and if I press over here, you see the image is reversed. So the image will be created in a reverse order. So in order to fix that, as soon as you see I press the R button, the GE from here move to this side. Again from the right to left and from left to right. So we need to first orient the probe in a correct way. We need to find the marker. In different machines, you will find that the probe marker can be a simple logo, their name, a dot, or whatsoever. But alternatively, I've told you the way to find what is the orientation of probe just by placing your finger on one end, and then you can find out that okay, this is the right side and this is the left side of the probe. Similarly, from top to bottom, this is very logical and easy. From top to bottom, this is superficial and this is deep. This is superficial and this is deep. On x-axis, it can be right or left, or you can say lateral or medial. And from y-axis, from top to bottom, it can be superficial to deep. So from this, what we can make use is that we can have an imagination about what is going on, or we can imagine that what is superficial, what is deep, what is right, or what is right lateral, and what is left lateral. Okay, so these are some functions. Now let's see if we can go for zoom. So if we zoom, you see it's getting bigger and bigger, and you can use the scroll, you can use the mouse to change the area. So this is when you want to zoom more and more, and when you want to come out of the zoom, you can press clear or zoom out. Similarly, you can change the ellipse area. Right now it's not there, but here I was talking about the body patterns or annotations. You can select, for example, if you are scanning the shoulder, you can select the shoulder. So from here you can select the shoulder. This is the shoulder region, and we can select sorry, uh, we can select the shoulder, and now you see this is over here, the shoulder is over here. We can select this, or we can click exit. We can change the position of this. We can place this to anywhere we want, and we can change the orientation of this arrow as well. Okay, so it's relatively, if we want to move the pattern, we can easily move the pattern. Okay, so not needed right now, then we can click clear and onto the comment. If we click and let's say write my name, it's creating my name. I believe you can see this. So it's adding a comment. Let's say Ali supraspinatus. So now you can see, this is just to make comments. We can clear the comments if we want, and we can click onto the preset to select the preset features or programs. So from here, you can see that there are a lot of programs like musculoskeletal. Is it more clear now to you guys? So let me Yeah. So the first one is ABD. It is for abdomen. Okay. This one is for abdomen. This is for obs. Can we increase zoom? Now it's clear. So this is scanning the abdomen. This is obs, gynae, cardiovascular, and this is vascular only, urology, small parts, pediatrics. And in the small parts, you can see if I click, for example, abdomen, it's going to load the abdominal settings. If I select the OBS, it will give me OBS setting, and then you see fetal echo, OBS 1, OBS 2, then gynae, but we are not related to these, so we will simply click onto the small parts, and once we click onto the small part, it can give me a list of options, breast or thyroid or scrotal scan or small parts or the musculoskeletal, so I can click onto the musculoskeletal, and now I am again at the very same stage where I was. So then this is basically the orientation of the screen. So from top to bottom, once again I'm telling you, from top to bottom it is superficial to deep, from right to left it is right lateral and left lateral depending upon the marker of the probe. Then this is showing us this whiteness is showing us the acoustic output, and in terms of TGC, if you see, let me unfreeze it, can you see, uh, let me stand corrected please. There was a change in something. Let me show you guys. This whiteness is showing you the acoustic output, like I said before. TGC is this, actually this line. If you watch this line closely, you will see the line is getting to the left side, means less bright. Line is getting to the right side, meaning more bright. So similarly, it has different regions, like 8 regions, and you can specifically fix a region. You can increase the output of the machine using this. So you can set it manually. It will take some time, you know, you need some fine hands. This is fine. Now let's fix this. This is fine. Let's fix this. And this is fine. Okay, so all of the features are shown over here once again. So if you want to recall, we can pause and we can repeat it, or otherwise we can proceed. Okay, so I'll be waiting for your message in the WhatsApp. I cannot use WhatsApp over there. So let me see what happened. Everything is fine. Okay, acoustic output is the actual power of the machine. Acoustic output is the actual power of the machine, so we can select and edit these settings from from the system. So what we can do is we can select the menu, and we can, let's go there, and we can select. There were a few settings that we need to. There was a menu button. Okay, let me, utility. So here you can see, you know, you can set these to any way you want, and from here you can go to advanced also. Application is shown over there, not needed, and let's exit. Apart from that, there is one more setting. Let me see, acoustic output should be in the mode. When we select the B mode, you click onto the presets, and you can change. Let me just sit, and let me see the keys first, because I can use these keys. There were the menu select. Yeah, just give me a second. This is not good. Okay, so let me tell you guys, you have these keys. So once you click over here, you will see this is the power. You can change the acoustic output to, you can see it's getting lower and lower. It's just like the power of the ultrasound. Let's keep it to 50% right now. Okay, and let's see, it has become less bright, and look at how the image is being made at acoustic output 50%. I will not change. I will simply go over here. I will keep on increasing the acoustic power so you can see the differences. Can you see the image getting more brighter on top? Sorry. You are not watching it. So I want you to see. Let's see. Acoustic power, middle. Uh, Reconnection, okay. Similarly, last thing is suppression. We can create some suppression if you want, but let's keep it to 0. So that's how you can edit the modes of the machine. These are just the settings. Let's not get into these, because most of the people, they don't change these settings. They only change the gain, the frequency, the depth, and sometimes the uh, gain, as well as zoom and right left. Let me show you one important uh, feature of this also. You can see, if I create, let's say, right and left, so I have created two images side by side. This is the right side, this is the left side. So like I've told you, for comparison, you can click the right and left side, or you can see the right and the left side. Okay, so that's pretty easy, makes no difference, and that's all for this. So we will take a short break, and then we will discuss theoretically how different structures they appear in musculoskeletal ultrasound, and inshallah For the next two sessions, we will be scanning upper and lower extremity. So, okay, so let's start with the more theoretical components of this lecture. So we will see how different tissues they appear in ultrasound, and first let's discuss how the muscles they appear in the ultrasound. Is it clear, or where do you see my picture actually? Where is my picture? It's on top. Yeah, it's fine. Okay, that's fine. Okay, so let's not discuss the anatomy of the muscles. We all know that what are the muscles, how they are made up of. So they have myofibrils, they have muscle fibers, muscle belly, fascia, blah blah blah. But one thing is that there is endomysium, perimysium, and epimysium, which are the layers of the fascia, and this fascia is appearing as white or hyperechoic in the ultrasound, whereas the muscle fibers they appear as hypoechoic. Okay, so this is very important. So if you look at, let me turn this to the pointer. If you look at these white lines, these are called as hyperechoic. I am repeating, these are called as hyperechoic. Hyperechoic means, you can give it to me, I can plug it here. Hyperechoic means when a structure is having more echo. Okay, hyperechoic means when a structure is having more echo, means it is appearing as more bright. So hyperechoic are the, I'm sorry, let me just check if it is connected. No, it's not. Yeah, sorry guys. Okay, so these are hyperechoic lines. Hyperechoic lines are the white lines that we see onto the screen. Then we have these black areas. These black areas are actually the muscle fiber itself. And then we have uh, more bright areas or more hyperechoic areas. These are the fascias, and these fascias are basically, separating the muscles. So like I've told you, endomysium, epimysium, and perimysium is there. So we cannot differentiate whether this is endomysium or perimysium, but we can definitely see an epimysium between the two muscles very easily. And sometimes the perimysium can be recognizable, but it's not what we want to do. So how muscles can be assessed? Any structure can be assessed in two ways. Okay, one is called as the long axis or longitudinal axis, and the other is called as the short axis or the transverse axis. The long axis means, for example, if we talk about the bicep, its long axis runs from the tip of the coracoid process, the short head actually, the tip of the coracoid process, and it inserts onto the radial tuberosity. So then, you know, this in this way, this is the long axis, and in the short axis, you sometimes call it as a transverse or short axis or cross section. So along the longest, let me make something I believe you can understand. Can we? Yeah, that's fine. So if we have a bicep muscle, it will be like this. Okay, so this is the orientation of long axis. So if we keep the probe like this is called as the long axis, and if we keep the probe like this, it is called as the short axis. So if we take any structure and we scan along its long axis, it is called as long axis scanning. And if we take any structure and we scan it through the shortest possible axis, it is going to be called as short axis. Okay, so this is the orientation of bicep long axis. So when we see the long axis of the bicep, that means that we want to see the bicep from top to bottom, or in craniocaudal direction. So the way the bicep is. So basically we want to see the bicep, and this is actually the origin, and this is the insertion of the bicep. Okay. So similarly, this is called as the short axis. Now this short axis is, why I'm saying this is as a short axis, because we are only looking at the, I don't know what is wrong with this pointer. So this is the short axis, this is the long axis. Of course it will take some time for you to understand it, but let's keep on practicing. Now this is again a long axis of the tricep muscle. So here is the olecranon, then we have fat pad and the tricep muscle. So, you know, within the muscle, what you will see fascia as tiny hyperechoic dots. These fascias actually, you know, in the short axis, these are the dots. In the long axis, they can be lines. Okay. Here you can see short and long axis of the muscle in ultrasound. In the long axis, they are white, bright lines. And in the short axis, they can be dot, or they can be some lines that are connected with dots. So there are different types of muscles: unipennate, multipennate, and bipennate. You need to know which type of muscle you are scanning and which type of fibers will be there. These are like just unipennate, bipennate muscles. Then there can be fusiform muscles. The fusiform muscles have origin and insertion tailored, while their belly is more big and broad. So unipennate muscles, there is only one angle of the fibers. In the bipennates, there can be two angles of the fibers, and in multipennates, there can be several angles of the fibers. So here you can see the fusiform muscle, and on the other hand side, you are looking at a bipennate muscle also. Then we can also look for intramuscular aponeurosis, and this is an example of intramuscular aponeurosis. How can we do functional assessment? We can make the muscle contract, and then we can assess the muscles. Okay. We can also visualize the difference in the thickness of the muscles, the cross-sectional area, its volume, and definitely you can also go for other testing as well. So important, if you are going to scan the muscles, please mind the following points. The patient should adapt a comfortable position so that initially there is a complete relaxation. This is important to standardize and to avoid misinterpretation of any findings. If a functional measurement is desired, you can initiate a muscle contracting while scanning. Always scan in two planes, both long axis and short axis, if you suspect the pathology. Please mind that hard pressure of the transducer leads to compression of the superficial anatomical structure. So if there is any inflammation or edema, if you press too hard, it will move to the side. So therefore, it is very important to press or scan the transducer, very lightly. Sometimes you'll have to add more compression if you are scanning a deep muscle, and sometimes you have to use less compression. You know, in that case, if you compress it more, you will be compromising the superficial structures, and you will be focusing more on the deeper structures. So that's all, but let me show you something. Let me turn this off. Now you can see my screen. Okay, so I want you to understand something. What is meant by long axis? The bicep runs from here to here. Okay, the bicep runs from top to bottom like this. This is the longest possible dimension of the bicep. So if we place our transducer just like this, it's going to be long axis. If we place our transducer like this, it will be called as short axis. It is similar to as if you want to cut my bicep. So if you want to make long strands, it will be called as long axis. If you want to have small slices, it will be called as short axis. So what will be, I'm just asking you this question, what will be the long axis of my pectoral muscles and what would be the short axis of my pectoral muscles? I give you some time to think and we will resume again. Okay, so for the pectoral muscles, this is going to be the long axis. So if you place the transducer like this, it will be long axis, okay? And if you place the transducer like this, it will be short axis. So maybe we can have another schematic and I can make this point more clear to you. That's fair enough. Can you see this image? Okay, so if you see this image, you can clearly see that this is actually the, let me change no, I cannot change the cursor in this. So I want to read this image for you guys. So here you can see this is the S. S is showing us the probe marker. This is the side. It can be the left side or it can be the right side. But this on top is the superficial one. If you move downward, it will become more deep. Okay. So superficial and deep. This can be mediolateral or craniocaudal. This is very important now. Depending upon the orientation of the probe can be mediolateral, the probe can be craniocaudal. So we have to understand the orientation of the probe. If the marker is towards the head, if the marker is towards the head, it is called as craniocaudal, this way. But again, the y-axis will always remain the same, that it will be from superficial to deep. Okay, so once you start scanning, you will see that there is this layer that is called as the skin. Then you have superficial fascia, and then you have this subcutaneous fat, and below that you will have structures. So because this is from an ankle, and they want to see the ligaments, and if you I don't know if you can see, but this is one of the ligament and this is the other ligament. At the lower ligament, you will see that this line is not continuous, rather it is breaking at this point, and this is actually the ligamentous injury. And this is telling you the marker of focus. So this is the point of focus for this. It should be, if it were over here, this image could have been even better. So similarly, there are different ultrasound images, and I can also try to show you some other images as well. uh, Let me show you. This is a very good image to show you. Sorry for the delay, but I want to show you something. Now you can see this image over here. So as soon as we start to scan the tissues, we see that this is the probe marker over here. So the probe was oriented to the right or the left, you can identify yourself. Okay, and then you have the skin, superficial fascia, and from the superficial fascia you see this is the one layer of the muscle. This is actually muscle. If I zoom it in, I don't know if we can, it's not zooming in. So this is the muscle, and again this is the muscle also. This is the tendon of the muscle, and this is the bone. They all look same. It's quite difficult for you guys right now, and they will all look same. Why? Because this picture is out of reference for you. You don't know the reference point. So as soon as I start to tell you the reference, you will definitely try to understand it. So for this to have, this is again, this image was created by me using the Hitachi machine. And then if you want to read the screen, you can clearly see these dots: 1, 2, 3, 4, 5, 6, 7, and there was another 8 one. These dots are actually TGC. This is the focus position. This is showing us the depth. Then these are the numbers, and everything is shown over here. So we were using the L54M probe and brightness gain and blah blah blah, everything. Okay, and this is frame rate 21. So what I want to tell you through this is that it needs some time before you can really grasp these concepts in a good way. So I will definitely, once we finish this session, we will go for a more friendly discussion and I will make more out of it. Now, how the tendons appear. Again, similar to a muscle, a tendon is also, I believe you can see my screen. Yeah, you can see. So the tendon, they are also having fascias, epitenone, peritenone, and endotenone. So there can be primary bundle, secondary bundle, tertiary bundle, and tendon properly. So the tendons similar to muscles, but they are having less water in it. The muscles are having more water in it. That's why they appear black, and they have less fascia. A muscle has less fascia as compared to a tendon, whereas a tendon has more fascia into it and less water. Okay, so this is the appearance of tendon. If you look at this, you see there is sandy or grainy appearance, and these are fibrilinear lines. What I am saying, fibrilinear lines. Fibrilinear means that they are in the in the form of fibers, as well as they are linear. Fibrilinear, so they are just like parallel lines, white lines with very minute black lines. Okay, so hyperechoic tendons are hyperechoic in nature. If someone asks me, okay, if this is a short axis or a long axis, then what I mean is, I can show you. Here, see, they are like this. The tendons are like this, fibrilinear. So they are having more hyperechoic areas and less hypoechoic areas. Okay, and they are fibrilinear. And now I believe you can easily see it is a long axis. Why I'm saying this? Because the tendons are, when you view them in the long axis, they are like this. Okay, they are like elastic band. But when you cut the elastic in the short axis, it's just a line actually, or oval in shape. So here, this is the long axis having fibrilinear pattern and similar to an elastic that is stretched out, or similar to a belt. Whereas in the short axis, they are more oval, or they are more rounded. Okay, so this is the appearance of tendon. It is important to scan the tendons using 90-degree angle. Let me explain you why. For tendons, it is rule of a thumb to scan perpendicularly using 90 degree of the probe. So from the probe to the tendon, the angle should be 90 degrees. Okay, here you can see this image, and the point where there is a steric, you will see that this is actually, this whole area is hypoechoic, black area. So it might seem that, okay, the tendon is broken from this side. Okay, so this hypoechoic or anechoic region is showing as black area, and we might mistake, we might make a mistake, and we may consider that this is actually a lesion in the tendon, whereas it is not. Sorry, see, you might consider that this is a lesion, and it can be an anisotropy. This can be an anisotropy, any, because of improper scanning, you were unable to see or visualize this part of the tendon. So this is called as anisotropy. Okay, it can be an artifact. Now, as soon as the transducer was changed, you can see that the black portion was gone, and you can see a more brighter part in or image in this area. So it is showing us that okay, because the ultrasound probe was not placed correctly, so that's why it was appearing as black, anechoic, and it was appearing to be broken. But as soon as we have scanned the tendon using 90-degree angle, then the tendon becomes more obvious and there was no lesion. So in ultrasound, there's a lot of anisotropy. Anisotropy is, let me tell you what is anisotropy. Anisotropy is something you cannot see what is actually there. Something you cannot see what is actually there. This is called as anisotropy. And there is some other thing that is called as an artifact. It can be something that is not there but you can see. Okay, sometimes something that is not there but you can see. And artifact can be any mistake also. Anisotropy can also be an artifact. So here in this picture, they are showing you what is happening when we talked in the first lecture that the ultrasound, it works on the principle of echoes. So echo means reflecting sound. So once you scan this area and this bone is not perpendicular, this tendon is not perpendicular to the transducer, what is happening that the ultrasound beam is coming over here being reflected to the other side and you don't see it. If you angle your probe like this, then the ultrasound beam will hit this area and go back to you and you will have a clear image. Okay, so this is what is happening and that's why you are getting anisotropy. So if you place the transducer in a different way, then the anisotropy can be gone. That's the whole point, that in order to understand the tendons or to read the tendons, to scan the tendons, we need to use perpendicular scanning or perpendicular technique. And this is very easy. We need to understand and remember the fact, if there is an anisotropy, we need to change the angulation or the position of the probe in order to see if it is really a ghost image or if it is a pathology in itself. Okay, so 90-degree or perpendicular scanning and both long and short axis. So this is actually what's inside the tendon. There's a fibrilinear pattern, and because of this, there is one problem. If you don't stretch the tendon, if you don't stretch the tendon, you won't be able to see the tendon clearly. So for this, either do the isometric contraction or you put the tendon in slight tension. Okay, so because of this, there will be poor image of the tendon if you don't stretch it. Here you can see the echo is being reflected to another source, and in order to correct it, just a bit of stretch should do that. So different types of tendons, bone and tendon, and this is peritenon and tendon, and this is tendon lined with peritenon again. So tendons can have avascular zones, especially the supraspinatus. Like this, for example, they are showing supraspinatus. This particular area is avascular in nature where A is written, and this becomes area of pathology most of the time. So you can easily, this is not an ultrasound image actually, but this is just to tell you that there are certain regions of the tendons, or there are certain tendons in the body that are having avascular regions, and they are more problematic, and you should always scan those areas for potential tears and traumas. Here, for example, you can see this is the supraspinatus. It's a cross section and it's showing us the lesion in the supraspinatus tendon. Okay, so this is true for the gastrocnemius tendon as well. The lower portion is also, having some problems, and 80% of the rupture, they happen in this region. So scanning position, the patient should be comfortable, tendon should be, uh, scanned using a bit of stretch. You can use an active contraction also or isometric contraction. You need to scan both in the long axis and short axis, and you can measure the cross-sectional area. The transducer can be using light pressure or deep pressure depending upon the area of interest. The key message is that, you know, tendons, they must be scanned using perpendicular scanning techniques. Okay, so in transverse axis or short axis, there can be multi-pixels or pixelated dots, and in the long axis, there can be fibrillary pattern or parallel hyperechoic lines. And anisotropy is a major pitfall, that there are chances you will, lose the or make mistakes while scanning the tendons. So let's go to the discussion part. The tendons, they, you can take any tendon. For example, you can take the tendon of tricep. So this is the tendon of the tricep. If you keep it relaxed and now scan it, it will give you anisotropy. So you need to stretch it and then place the transducer. So this is the long axis because this is the longest dimension of the tricep. And this, if you cut it from this will be short axis. So I'm going to ask you a simple question. If we want to scan this, let's consider that this is a pen. Let's make a marker. If we want to scan this, what is the short axis? Of course, if you place the probe like this, it's short axis like this. And if you place the probe like this, it is long axis. So long axis can be from this side, from front, or from right side, from left side, depending upon. But short axis can be from any side and it will have similar area like cross section. So for tendons, it is 90-degree or perpendicular scanning. We will always use a bit of stretch. We will use scanning techniques that involve tendon in a bit of stretch or in isometric contraction, and we will definitely look for pitfalls that are anisotropy and artifact. With tendons, if you don't scan perpendicularly, if you don't apply a bit of pressure, or if you don't know the anatomy, there will be a lot of pitfalls. Okay, for the muscles, it's a lot easy, but for the tendons, it's a lot difficult. So in the long axis, the tendons, they appear as fibrillary lines. In the short axis, they appear as oval appearances, oval shape appearances, or grainy appearance. That's all about scanning the tendons using ultrasound. Okay, I hope I made myself clear. I'll be waiting for your messages in WhatsApp group. Okay, so let's start with the last lecture of today because it's quite difficult to absorb a lot of things, and maybe we can have some more discussion if the things are not done. Okay, so how do you think the bone will appear on ultrasound? So I will briefly or quickly let you understand what is the appearance of bone. The bones, they are actually not letting the ultrasound beam pass through them. So because of this, we cannot see the whole bone. We can see only the periosteum of the bone. And this periosteum actually appears as the hyperechoic. And what is the difference between a bone and a tendon? A tendon actually will allow the ultrasound waves to pass through it, okay? Whereas the bone will not. So the bone will be the most brightest structure that you will see in ultrasound, number one, metal and bone. Secondly, there will be posterior acoustic shadowing. So I will not go into the detail, but you will see the image and you will understand what is meant. The posterior means that posterior to the bone. Acoustic means the audio or the waves or sound waves, and shadowing means blackness. So past the bone, you will see the black area. So let's see. Here we go. There we go. There we go. Let's see it. guys can see this. So this is the bone and ultrasound. So they have placed the transducer. This is called as a long axis or short axis. I want you to tell me in the WhatsApp group, please. Hurry up. What is this position? This image is long axis or short axis? Wait. Long axis. No, this is short axis. This is short axis, okay? So this is a short axis. This is short axis. Forget. If we take, let me again control options and laser control. If we see the bicep, let's go to and let's see the bicep. The bicep is like running from here to here. Now tell me if it is long axis or short axis to the bicep. No, the deltoid fibers are again like this. So for the deltoid also, it is short axis. Yes, for pecs it's long axis, only for the pectorals. Okay, so the point here is if you place the transducer, this is superficial. Okay, this is superficial and this is deep, right? This is deep and this is superficial. This is now if you look at the probe marker, okay, if you look at the probe marker will be over here. So this is the probe marker on this side and this is the right lateral, this is the left lateral, this is subscapularis, this is supraspinatus, this is the long head of the bicep, and this is the humerus. Past the humerus, you cannot see anything. Okay, past the humerus, beyond the humerus, you cannot see anything. It's just like you are passing a nail. Okay, if you imagine for short period of time that you are passing a nail from a person's skin. So first there will be skin, then there will be subcutaneous tissue, then there will be deltoid muscle, then beyond the deltoid these white areas, hyperechoic areas, are basically the joint capsules, and below this you will see the long head of bicep and then the bone, which is humerus, and you cannot go past the bone. Then this is absolute darkness, which is called as posterior acoustic shadowing. Okay, so stones are also here. I want you to tell me what is CL. CL is clavicle. ACR, acromion. This is the acromioclavicular joint, and past the acromioclavicular joint you cannot see anything because of posterior acoustic shadowing. So beyond the bone you cannot see. So see, you can see everything, but as soon as you go beyond the bone, you will see nothing, and this whole area is posterior acoustic shadowing. That means that this is bone. So if now you see a condition which is called as myositis ossificans, you were scanning a muscle, and in the muscle you see a region past which you cannot see anything, then this will be called as calcification or myositis ossificans. If it happens in the tendon, it can be calcific tendonitis. If it happens in the kidneys, it is renal, stone. If it is in the gallbladder, it is cholelithiasis, blah blah blah. So bone is having posterior acoustic shadowing. Just remember this: posterior acoustic shadowing, posterior acoustic shadowing. Here you can see we want to see the thickness of the quadriceps, the thickness of the femoral cartilage. We can see the thickness of patella. So we can easily patellar cartilage actually. So we can see that this is the trochlea, okay, femoral trochlea. This is quadricep tendon, and this is the cartilage of the femur, femoral condyles or the femur. Okay, so this hole is the cartilage of the femur or femoral condyles. So the bone is hyperechoic and there is posterior acoustic shadowing. You cannot see anything past the bone, and the cartilage is hypoechoic as compared to bone, and you know that it is adjacent to the bone. And then look at the QT, which is quadricep tendon. This QT means this is the quadricep tendon, and this tendon actually is hyperechoic in nature, and this is a short axis. Okay, this is a short axis of the quadricep tendon. Then there can be some artifacts which are called as mirror artifact, that you see two images of one thing. This is common in the bone scan. While you scan the forearm, you sometimes see the mirror artifact. Okay, sometimes we can see multiple layers of the same image, then it will be called as reverberation, that the ultrasound beam, it keeps on moving to and fro between different structures, so it makes 4 or 5 copies. If it is a single copy, it is called as mirror artifact. If it is 3, 4, 5 copies, then it is reverberation artifact. So here you can see this is mirror artifact. Then you cannot see the developing bone, no need to do that. Cartilage is, like I've told you before, it is hypoechoic or black in color. So this is the elbow joint. In the elbow you can see capitulum, trochlea, and this black line is showing you the cartilage. Okay, so bone, past the bone you cannot see anything. This is all black, posterior acoustic shadowing, and in the cartilage you can see the dark areas. So the dark area is hypoechoic area. So for the cartilage, you can measure the thickness. It is fast, pain-free, non-invasive, and it is reproducible. Okay, so there are a lot of ways to use this ultrasound. So that's all for today's lectures. Let's